Do you treat every paper you read as good evidence because it's been published? You might think that all published studies are credible and good quality, but it turns out that some published studies have more weight and dependability in medical science than others. And in this video, I'm going to share the different levels of evidence so that you know which studies are the highest quality, how to choose the best sources to cite in your writing, and even what level you want to aim for in your own work. And if we haven't met, hello, my name is Crystal Heron. I'm a trained biomedical scientist turned clinical researcher and now scientific and medical editor. And since 2011, I've helped scientists, clinicians, and other professional writers master the craft of writing so they can write with intention and maximize their impact in their field. So what is the hierarchy of evidence? So the hierarchy of evidence is a framework for ranking the rigor or the strengths and reliability of various types of research. And this framework helps researchers to critically evaluate research so they have strong work to support their rationale for future work. Also, when they cite quality work that is more credible, they appear more credible. Now, this framework also helps clinicians and policymakers to critically evaluate research so they can prioritize high-quality evidence for healthcare guidelines and policies. So this framework is valuable not just from a clinical standpoint, but also from a research quality and credibility standpoint. So the hierarchy of evidence is shaped like a pyramid that ranks the quality and dependability of research methods in medical science. And the higher up on the pyramid, the more rigorous the methods and the less likely the results are affected by bias. Let's start with the bottom of the pyramid and work our way up. I'll share a little about what's included in each level and a few high-level pros and cons that influence their position in the hierarchy. Level 1 includes in vitro and ex vivo studies. So these studies include experiments on cells, tissues, or molecules outside a living organism. For example, cell culture experiments, tissue or organ experiments, or biochemical assays. So this research involves highly controlled bench experiments that researchers use to probe mechanisms, molecular targets, and basic biological effects before anything is tested in living beings or in vivo. Now, these experiments have tightly controlled variables and a tightly controlled environment. And they're also lower cost than animal or human research, and they can be faster to complete. And they're also great for things like high throughput screening for compounds or drug development. And they're also essential for understanding mechanisms and identifying candidate drugs or targets. On the other hand, in these systems, researchers don't have the full context of the whole organism. So they can't see how changing something in one cell type or system might affect another cell type or system. Also, the effects seen in cells don't always translate to animals or humans, and you can't really directly answer clinical questions about patient outcomes. And as a result, these studies are really important for informing research in higher levels of the hierarchy, and in many cases, they are the foundation of them. And this is why they are at the bottom of the pyramid. Now, level 2 includes animal and preclinical studies. So these are experiments in non-human animals, such as mice or rats or primates or other animals. And they often focus on testing the safety, the dosing, and the biological effects that are often revealed in vitro and ex vivo studies. So in other words, they are a bridge between in vitro work and human studies. And they're used to explore disease models, systemic effects, pharmacokinetics, and preliminary safety and efficacy. Now, these studies are great to get the context of the whole organism, including the different organs and the body system as a whole, which can also give insight into metabolism, toxicity, and other factors. And with these experiments, you can often do invasive procedures and long-term follow-up that can be impractical or unethical in humans. And this is also a required step for many drugs and interventions before they move on to human trials. On the other hand, there are biological differences between animals and humans that limit the generalizability of the findings to humans. And there are also ethical concerns and regulatory constraints when you are working with animals. And although you don't have that with in vitro work, it means that the work is more carefully thought out and carried out, which improves the rigor. The other challenge with these experiments are that they often include small samples and even disease models that are somewhat artificial and mimic signs of a disease rather than the full extent of the disease. And as a result, these studies are really important for informing human research in higher levels of the hierarchy, which is why they are just above in vitro and ex vivo studies, but below human studies in the pyramid. Level 3 is expert opinions and narrative reviews. So this includes opinions of experienced clinicians and researchers, and these often look like narrative or non-systematic reviews or consensus statements that are not tightly evidence-based. And so they are based on clinical experience, reasoning, and selective reading of the literature without systematic methods like a systematic review. And so these studies are useful when higher level evidence is not available or maybe emerging. And they can help to provide practical guidance and context, especially in rare conditions. On the other hand, because these are opinions and written by one or a few authors, they are highly prone to bias and selective citation. And they don't include a transparent, reproducible search of the literature or appraisal of methods like a systematic review does. So as a result, these pieces are valuable for summarizing areas of the literature, sharing perspectives, and encouraging new ways of thinking. But they are fraught with bias and should be considered carefully. Level 4 includes case reports and case series. So case reports are detailed descriptions of one patient, and case series are a detailed description of a small group of patients without a control group. And so these studies describe patients with unusual diseases or outcomes, or who were given new procedures or unique treatments. Now, these cases are helpful for signaling new diseases, rare side effects, or unexpected responses. And they can help to develop hypotheses, guide future work with larger groups of patients, and in some cases, inform the treatment of unique clinical cases. However, because they describe one patient or a small group of patients with no comparison group, you can't really infer causality or estimate the effect size. So these are more descriptive and they're highly susceptible to selection bias. And so this means that they have limited generalizability. So as a result, these cases are really helpful for spreading awareness, developing hypotheses, and guiding future work that is higher up on the pyramid. Level 5 includes cross-sectional studies. And these studies include observational studies that measure exposures and outcomes at a single point in time, like a snapshot. And these studies are used to estimate prevalence and explore associations between variables in a population at one moment. Now, because these are retrospective studies, they are relatively quick and inexpensive and good for things like public health surveillance. They're also useful for generating hypotheses and planning future studies. On the other hand, you can only assess correlations and associations, but not causality. And the associations can be misleading, such as in cases of reverse causality, when you might think that X causes Y, but actually Y causes X. So these studies are vulnerable to confounding and non-response bias, such as in survey studies. So as a result, these studies are informative in estimating prevalence and associations, but they are not great approaches to evaluating causality. Level 6 is case control studies, and this includes observational analytic studies that compare people with an outcome or condition to people without that outcome or condition. And so these studies are efficient for studying certain diseases, such as rare diseases, or outcomes with long latency, such as certain cancers. And because these studies are retrospective, they are efficient in time and cost, especially for rare outcomes. And they can help to assess multiple exposures or variables for a single outcome. On the other hand, these studies have a retrospective design, so they are susceptible to recall and selection bias. Also, you cannot measure incidence or directly calculate risk. And because they only provide information about associations, there is a higher probability of confounding. And so as a result, these studies are informative for rare diseases, looking at multiple risk factors at the same time, or to analyze links and exposures related to something like a disease outbreak. But they are not as strong as prospective studies, which we're about to get into. So level 7 includes cohort studies. And so these are observational studies that follow groups of people with and without an exposure or disease over time to see who develops an outcome. And these studies can be retrospective, where they use existing data, or they can be prospective, where they follow patients forward in time. So these studies are great for research on incidence, prognosis, and risk factors. And they can help to establish temporal relationships, such as exposures before outcome, to make stronger associations for causality. And they can also measure incidence and relative risk, so you can study multiple outcomes from one exposure. On the other hand, prospective cohorts can be long, expensive, and logistically complex, and you can risk participants being lost to follow-up. These studies also often involve confounding that can bias the results. And you can have less control over the exposures or interventions than more experimental designs. And as a result, these studies are great for evaluating incidence, prognosis, and risk factors that might indicate causality. Level 8 includes non-randomized and quasi-experimental trials. So these studies include interventional studies in which the investigator assigns an intervention to a participant group, but without true randomization. For example, comparing before versus after an intervention, or a controlled study that is not randomized, or an interrupted time series. And so these studies are used when randomization is impractical or unethical, which can be the case in health services or policy research. So it might be unethical not to give a certain group a particular treatment. Now, these studies are more practical and feasible in real-world settings, and they can provide stronger evidence of causality than purely observational designs if a study is well controlled. On the other hand, the lack of randomization increases the risk of selection bias and confounding. And it can be harder to be sure that the observed effects are due to the intervention. And they often have lower internal validity than randomized trials. And so as a result, these studies are great for evaluating interventions in real-world settings when randomization is not practical or is unethical. Level 9 includes randomized controlled trials, or RCTs. And these are experimental studies in which participants are randomly allocated to an intervention group or a control group who might get a placebo or standard care. And so these studies are also often blinded. And they are the gold standard in primary study design for assessing the safety and efficacy of interventions. And this is why they are so high on the pyramid. Now, in these studies, the randomization balances the known and unknown confounders, which helps to minimize bias. And blinding reduces the measurement and performance bias. And these studies also provide strong evidence for causality and effect sizes. On the other hand, these studies can be expensive, time-consuming, and often highly selective in inclusion criteria. And they also can have ethical and practical limits, and they may have limited external validity if the trial population is not representative. But overall, randomized controlled trials are really powerful studies that are a gold standard and highly credible study design. And they are at the top of the hierarchy when it comes to experimental studies. And above this point in the pyramid are 3 different types of evidence that do not directly involve experimental work in humans or any cell, tissue, or animal model. Level 10 includes systematic reviews, and these are structured, pre-planned syntheses of all relevant studies on a focused question. And so these reviews use explicit methods to search for and select literature and to critically appraise the literature, much like the research process. And so they are narrative summaries of all the evidence from multiple studies, and they often focus on randomized controlled trials for intervention questions, but they can also synthesize observational studies. Now, systematic reviews are a transparent, reproducible overview of the evidence base, and they have less random error than single studies, so they help to clarify the consistency of findings. On the other hand, the quality of the systematic review is limited by the quality and heterogeneity of studies included in the analysis. And these studies also tend to have demanding methods that can be time-intensive to complete. And they can become outdated quickly as new trials appear. But even still, systematic reviews are near the top of the pyramid for a reason. They synthesize evidence from multiple studies in a systematic way that mimics the rigor and reproducibility of the research process. And depending on the level of evidence in the review, such as if it includes studies lower or higher on the hierarchy of evidence, then the lower or higher the quality of the systematic review. Level 11 includes meta-analyses or quantitative systematic reviews. So these include systematic reviews that statistically pool effect estimates from multiple studies into a single summary estimate. And they are near the top of the pyramid because they provide a quantitative synthesis and greater statistical power than a systematic review. So these studies increase the precision of effect estimates and can detect effects that smaller studies miss. They also allow exploration of heterogeneity and subgroup effects. On the other hand, they are vulnerable to the quality of the evidence that's included in the analysis, much like the level of evidence in a systematic review. So in other words, garbage in, garbage out. And if the underlying studies are weak or biased, then the analysis may be weak and biased as well. And also, publication bias and selective reporting can distort pooled results. And the clinical heterogeneity may make pooling inappropriate or misleading. Even still, meta-analyses are near the top of the pyramid because they statistically pool multiple studies, which is stronger than a narrative summary in a systematic analysis. Level 12 includes umbrella reviews, and these are reviews of reviews or overviews of systematic reviews and meta-analyses. And they are at the top of the pyramid because they systematically collect, appraise, and compare multiple systematic reviews and meta-analyses to give a high-level view of the evidence landscape. For example, all interventions or all outcomes for a disease. Now, umbrella reviews don't appear on many pyramids because they are a newer level that has been growing over the past decade. Now, umbrella reviews give an overarching synthesis of high-level evidence, which gives a comprehensive map of what is known across many interventions or exposures for a particular condition. And so they help to identify consistencies, strengths, and gaps in the evidence landscape by comparing effect sizes, study quality, heterogeneity, and the risk of bias across multiple systematic reviews. So they have a lot of power in directly informing clinical guidelines, health technologies, and research priorities. On the other hand, they do depend on the availability and quality of existing systematic reviews and meta-analyses. So the same concept of garbage in, garbage out applies. And so quality systematic reviews and meta-analyses support quality umbrella reviews. Now, umbrella reviews can be complex to carry out because of the heterogeneity between different systematic reviews and meta-analyses. But umbrella reviews are the creme de la creme of evidence, the best of the best, which is why they are at the top of the pyramid. So these levels of evidence clarify the quality and credibility of the work that has been published, and the quality and credibility of the publications that you choose to cite in your manuscripts and grant proposals, and that you choose to inform your research and clinical practice reflect the quality and credibility of your work. So choose the best possible studies on which to base your work. And when you are citing works, be sure to consider all the elements of the publication and to avoid lazy author syndrome. If you'd like to learn more about lazy author syndrome, or what I prefer to call overburdened author syndrome, I'll add a link to a video that I created on this topic at the end of this video. And if there's something in particular that you'd like to learn more about, let me know in the comments. I create these videos for you, so I want to make sure that I'm creating something that you will find valuable. Thank you so much for watching. Have a lovely day, and I hope to see you in the next video.